Hi, everybody. I'm actually one of you. I'm a medical director in a DaVita facility. I'm also a group medical director for Fusion, so I have experience across the country going from Minnesota to Florida in about 16 states. But I'm also like you in that I'm hungry, and I know that I stand between you and lunch, so I'll try to be as quick as I can. So my task today is to talk about the DaVita Home Dialysis Medical Director. And for those of you that were with us yesterday when we introduced the role of the medical director to a lot of new medical directors and some more seasoned medical directors that took the course, it became very clear to me that the role of the medical director in a home unit is a different animal. So I'm going to talk about the differences and the strengths and weaknesses of what we need to accomplish. So the key characteristics of a successful home medical director could be the same as the attributes of all in-center hemodialysis medical directors. You have to be available and involved. We want you to be engaged. You have to be accountable and responsive. You have to be a clinical leader, and you have to be a coach. That's clearly taken out of the whole design of the QIFM, where you are the clinical leader of the group as well as the coach for that group. You need to be quality-oriented, and you need to be a team builder. So today we have a different audience, and this group is all interested in home. So let's look at it a little bit differently. Does the average DaVita medical director really embrace the home dialysis opportunity? I guess the data expressed this morning says it's not really happening yet. The major emphasis has always been in-center hemodialysis. So do peritoneal dialysis and home dialysis require a different approach? Well, in DaVita right now, we have about 142,000 patients that are on dialysis in 1,809 facilities. 10%, which I upgraded my slide this morning, are on PD, and 2% are on HHD. That's way better than the national 7%. But we still are on that far left side of the slide that Alan produced. By using the math, the average facility has about 78 patients, and then I looked at it in terms of stations. Usually most facilities have 20 to 40 stations with 2 to 3 shifts, so therefore you're probably experiencing that your units are holding 80 or less patients to up to 240 in center. And when you do the calculations, it looks like most centers have exposure to about 5 to 17 PD patients and less than 3 HHD patients. And that infrastructure is fully designed for in-center hemodialysis care. Now, the reality is there are clusters of emphasis on home dialysis. We hear about it at the national meetings. We hear about different stories here. So there are regional influences. I know that working with Team Fusion, when I get up into the far north and the Midwest, where it's a long distance to get to the in-center hemodialysis facility, PD is actually going to happen more frequently, and home hemodialysis is starting to grow there as well. And we saw on John's slide that there are some real champions of home dialysis in that area. And as you travel across the country and you know the facilities in your area, you may see that the regional differences may be affected by geography. In most cases, I think it's because someone championed the cause. And then we saw in many of the slides earlier that it sometimes is economically driven in other countries. And we say, what's going on in the United States? Well, in DaVita, there's a new emphasis on home dialysis, and it's relatively new. But it has required a huge amount of new infrastructure. Things like having this meeting today and the one that we had last year. Things like bringing on a whole group of new teammates, and in John's slide he showed the growth of the number of new teammates for home modalities. It's required the company to take on a whole new leader for home modalities in Dr. Moran and the team that he's put together. It's required a total refining of the approach to care of patients within our facilities. Now when we roll out protocols, we have to roll out home-designed and home-specific protocols for the different things that you do in the automatic treatment of your patients. And risk management has to identify that now we're taking on a whole different animal as far as how we deal with the risk of taking care of patients. But we're nephrologists. We take care of patients with CKD, and we offer them all modalities of dialysis, as well as transplantation, as well as withholding or non-dialysis. So when we look at the studies about comparing one modality against another, sometimes, at least myself, I have a hard time looking at my patient and saying, okay, I'm choosing, or we're choosing for you to go on PD, and this is the curve you're going to follow. I see the continuum of care for the kidney patient to be very, very, very important. And I think that we as physicians and nephrologists should be masters of finding a way that we can have our patients live within that continuum, possibly going from one modality to the next, such as what was exhibited by George, and so that we can actually offer them an umbrella of care that may include several modalities with the highest quality of life as well as quantity of life, and let them choose the ratio of quality versus quantity. I also want to say that this group is a courageous group. We represent the care of 1.5% of Medicare's patients, taking care of late-stage CKD patients and dialysis patients, but we're on the radar screen. We're costing this country's Medicare budget 10% per year. So if you don't think we have a target on our back, you're crazy. We are definitely under the watch. So when we look at the cost, the pie that we serve up to Medicare, we see that the annual spend for ESRD patients globally is around $90,000 a year. And if you look at the big orange portion of the pie related to hospitalization, we see that this whole phenomenon of taking care of patients on dialysis is incredibly expensive. When we choose a home modality, and particularly in this case PD, we serve up a smaller pie. The cost is closer to about $60,000 a year, and the portion that's related to hospitalization is much lower. In our practice, our PD population and HHD population consume 1/5 the hospital days per year as our in-center hemodialysis patients. So when we look at what we're saving for our country, just in our population of patients of close to 500 patients, we're saving several $1,000,000 by avoiding hospitalization and a less expensive modality of care. So while I want to talk to you about the medical director, I want to talk to you about our group's experience just so you can understand that in our town of Ocala, Florida, which is in Marion County, Florida, which is north central Florida, which is about the size of Rhode Island. We have about 320,000 patients in our county. We have 26 to 27% of our patients are over 65. By the US statistics, we're the oldest county in Florida, which means we're probably one of the oldest counties in the country. We have a poor payer mix, and we're taking care of people just like you. In 2003, at that time, we were taking care of about 300 dialysis patients out of 4 facilities. We had about 35 patients that were on PD. And I was pretty frustrated with not being able to grow the PD program, but also with the fragmentation that was required with taking care of patients in multiple facilities with that similar dogma of no more than a few patients taken care of by a fragmented group of people. So I went to Medicare and tried to get them to see us able to do multi-care out of multiple facilities with one common number so we could bring the team together. Medicare would see nothing of that. So after I lost that argument, I went to DaVita and said I want to build a home-only program. And I want to emphasize PD, build HHD as it becomes available, look at nocturnal. And if you help us do it, in 10 years, we will take it to the max. We modeled the facility to take 140 patients. And now, in 2012, out of our 480 dialysis patients in our 5 facilities now, we have 105 PD patients, 16 HHDs, and we were going to break our prediction of exceeding the capacity of that facility in 10 years. So how did we do that? Well, when we were trying to design this facility and talking to our teammates, we found out that it was different in every way. Our facility function was different, organizational development was different, our team had to be a totally different team, and I cannot underscore that more. I'll talk about it more. We had to build different protocols, and we had to look at our continuum of care within the community. We had to look at building a nephrology ward in the hospital so that we could take care of the patients and not have them be destroyed by emergency rooms and things like that. We found it was a totally different infrastructure that was necessary. So as we were talking to the new medical directors yesterday, one of the things that we talked about after we reviewed our performance, those of us that were helping to carry on the course, one of the points that came out was the DaVita culture really does work, and the core values need to be driven home to medical directors. And as I was sitting there thinking about the entire day being spent mostly talking about in-center medical directors, I started thinking about these core values and how they apply to the home dialysis medical director. Now, recognizing that many of you are still in an in-center world and you have a PD program or a few HHD patients in that in-center world, and some of you may be lucky enough to have a spun-off home program, let's think about how you apply those core values to your application of home patients. First of all, service excellence. When we built our new facility, we have a small waiting room. No more than 2 or 3 patients can wait at a time because nobody ever waits because they're going in to see patients, or they're going in to see our team right away. And they're only going there twice a month. They're not going multiple times a week. Our service excellence has more to do with how we answer the phone, more with how we preemptively call them and check on them, more to do with how we manage their time than about how we manage our time. It has more to do with how we give first impressions than it has to do with whether we get them, something while they're on the machine. It's a total different way of thinking. I don't know if anybody could have called us out more on integrity than what just happened with the last speaker. How can we say one thing and do another? That integrity also carries through to our patients. Now that we've included the patients in our care plan so much more with a home modality, we have to impart upon them the importance of integrity and knowing that they've got to be honest with us. And again, team. I can't speak more for how important it is to build a team that is devoted to keeping patients healthy and happy at home. It is a totally different approach, and every single person in our facility is valued to the highest amount. Continuous improvement. Our QIFM meetings are exact. We go over data. We constantly are looking for improvement, but we're looking for improvement that's involving the patients improving their own care. It's involving their caregivers in the whole continuum. It's a larger opportunity because you have so many variables that are outside of the facility. Accountability. We now have extracted accountability to the home, to the caregiver, and to the patient. And that's a big deal. You have to have that close relationship. Fulfillment. What could be more fulfilling than to know that your patients are not in the hospital, that they're at home, that they're sending you postcards from their trips, they're coming back from cruises twice a year, they're going sailing when they used to be homebound. These kinds of stories are not extreme. They're common with the home dialysis population. Fulfillment is something you can enjoy as well. And I have to say that fun is still a huge core value for us. I now, when I have my clinic, I spend 4 days a month just seeing my home patients. And it's like a pediatrician with well baby checks. It's total fun. So getting back to the characteristics of a successful medical director for the home program, they'll have further attributes beyond that of the in-center hemodialysis medical director. They'll be a student of a different scientific body of evidence, as was exhibited this morning. We have to stay in touch with that body of evidence because nobody else really knows about that. We believe in a power of home dialysis in the lives of patients. We hear the testimonials. We have to believe in them because that will give us the courage to stand up and go beyond the limits of what everybody else says could be done. We have to be a team builder in a different way. We have to value our teammates and we have to value our patients. Does anybody recognize that February is also National Caregivers Month? So we had a program within our facility to celebrate our caregivers, and that was brought up in some of the information earlier. We have to build a team that involves the patient and their caregivers as well. It influences patient care way beyond the facility. We have to have hospital resources, we have to have community resources, but we have to get the word out there that these patients have to be treated differently. Our emergency room now knows that if someone comes into the hospital with a larger belly than the average and they're holding it, they're either pregnant and in labor or they're on peritoneal dialysis. We have to be willing to go outside the box. So, why more patients are not on home dialysis? So the question is, what modality would physicians choose for themselves? The top three are home hemodialysis, peritoneal dialysis, and nocturnal hemodialysis. That's been shown in multiple studies. That's what we would choose. Say what you say, do what you do. Suitability of patients for home dialysis. We talk about the ideal patient. The previous speaker said, don't get so restrictive about that. And the speaker before that said, basically you need to have a peritoneal cavity that can take a catheter and a home. Personally, my home take-on rate is 65%. It's doable. I'm a physician seeing the same kind of patients as you are. We can do this. So ultimately, the feasibility of home dialysis may be more dependent upon the capability of the program than the patient. So that program consists of a medical director who is a coach and a clinical leader who is important in building and sustaining that program. So we have to learn to say yes. We have to get rid of the thought that we should say no so often and find a way to make yes be the answer much more frequently than what it is. And if you take that list of absolute contraindications and relative contraindications and choose those to be the challenge before you to eliminate the barriers to starting a home program and to building it, you can see that it can be done. And I'm one that can tell you that as I'm here at the breakout sessions, I'll give you everything I can to tell you how to do it. DaVita will give you everything necessary to be able to do it, and we can beat this monkey. So, further tips to ensure that the program thrives and grows. The program will thrive on good outcomes. The less churn, the good outcomes will lead to fewer losses from complications, as Dr. Moran refers to churn. You'll have a timely transition of PD to HHD. You'll have those fistulas in place, and why couldn't a PD patient that has to transition go to HHD? You'll have happy patients who will attract others. Our footprint in Marion County extends beyond our borders because of happy patients telling others. The team is very service-oriented while focusing on empowerment of the patient. Now, sometimes that empowerment gets in the way. We were in our last QIF and we were frustrated with our peritonitis rate because we had noticed that if we drilled down that some of our sickest patients that should be getting peritonitis were not, but some of our seasoned patients had gotten peritonitis from little things like they repaired their own catheter. Because when you have a patient that stays alive for 10 or more years on PD, that catheter starts to get a little bit old and they start to break. And so they'd seen our team carefully clean everything up and fix that catheter. So they're so empowered now, they think they can do that themselves. And one of them made the mistake of blowing on the alcavis afterwards and got a little peritonitis. So even though you think you got it figured out and empowerment is the way to go, you still have to learn, constantly be teaching yourselves. Problem management and prevention will resemble that of an extensivist practice and will avoid hospitalization. And what I mean by that is, as you know, an intensivist is a physician who works in the intensive care unit, intensively taking care of a very small number of patients with very sophisticated tools. An extensivist works to keep his patient out of the hospital, doing everything possible in the community to provide the care for that patient and avoiding any reason for that patient to go to the hospital. That's where we work hardest, is to keep our patients from having to go to the hospital. If hospitalization is necessary, the team needs to stay very involved. Our team doesn't just sit back and wait for the patient to show back up with a medication reconciliation that doesn't make sense. They're involved and they're calling the hospital, they're teaching the hospital nurses. Growth, you have to focus on the incident patients, having the choice to go home first. You have to create a culture of change which introduces modality selection during CKD care. You have to eliminate all barriers to selection. You have to create outreach to the prevalent patients in the in-center world, and you have to have self-care protocols in your in-center patients, which will further allow them to have the empowerment curve to become self-care. You have to manage losses. Our first home hemodialysis patient, after a month of training, we celebrated his graduation to find out the next day he was called for a transplant. But we celebrated his transplantation anyway, and we still celebrate those transplantations. The data will teach the reasons for other losses. We drill down to eliminate those reversible causes, and many of those reversible causes will not be medical. They will not be within the context of something that your team did, but most of those will be solved by your team. And I can't emphasize that less. Hemodialysis is a great resuscitation mode. Somebody shows up in the emergency room mostly dead from renal failure. You can resuscitate them with an acute hemodialysis treatment. It's a wonderful life-saving trick. Home dialysis, my team, our team, are social resuscitators. We present to them a patient who has medical illness. We give them the tools to take care of that medical illness, but they work so hard to make that patient's life work, and they resuscitate the social part of that patient's life through the caregiver, through the economics, through the support that's necessary to make that patient's life come into play. And within 3 weeks, 4 weeks, the patients are socially resuscitated. Within 4 months, they're very independent. So otherwise, build upon your successes. Let others know your story. So that's why I've told you a little bit about my story. We now have, as I said, about 121 patients on a home modality. 56% of my own personal patients out of 75 as of last week are on a home modality. So let others know your story. Champion the causes of your patients. I could go on and on about that, about the patients that can do things that they weren't able to do if they were on in-center hemo. And champion the caregivers. You've got to recognize. In our study, or in our dealing with our caregivers this month, as we celebrated the caregivers, one of the questions came up: what is the ideal caregiver at home? And we went through our list of all of our patients. Look at that caregiver. This one's a really great caregiver. And then we say, well, but that one would never match that patient. So what I've actually noticed is that our team actually has learned how to optimize the caregiver-patient relationship. And I know there's got to be some science behind that, because that's not something that's talked about much. But our team actually puts together the characteristics to make those relationships work. And then I can't underscore more to focus on the incredible power of a highly skilled, highly collaborative, and knowledgeable team, and do everything necessary to support this team. Your role as medical director is to be the coach, just like the coach for your kids and the soccer team, just like the coach for everything. You have to be their coach. You're the clinical leader. They look to you for the leadership. They look to you for the clinical data. Don't let them down. But in addition, stay their coach and their friend that will pay you back in spades. Thank you.